Hi everybody. By now, hopefully you watched my prior video about understanding third-party insurance. It's an older video, but it hits a lot of the detail of what still is relevant here in 2019. But I wanted to do a follow-up video lecture, just kind of giving you an overview of what goes on in a traditional community pharmacy. But I also want you to think about too, and I've gotten to talk to several of you so far um, in our Zoom meetings, and a lot of you have some great ideas, and some of them are not traditional pharmacy ideas, and that's awesome because that's the purpose of this course is to look what are those business opportunities. So let's just talk about ways pharmacy could get paid. So if you look at this picture, and I shared this picture way back when I taught you American healthcare, that, it was a lot easier, if you go back 40 years ago, because the majority of how any pharmacy got paid was via cash. Obviously, the demand in insurance benefits um, expanded for private companies to cover prescriptions. But the biggest thing that we saw in this whole increase in coverage, and in the early 90s is when managed care came into existence, that unfortunately drug prices escalated to what they are today. And the difficulties of those have led to most people can't afford sometimes their medications. Third party insurances are pretty much the majority of all your business, whether it's in Medicaid or Medicaid, and cash business in a traditional community pharmacy may be anywhere from 2 to 3%. My prior lecture talked about who are the players, and the biggest challenges we have in community pharmacy today is the way that it's run. And the way that it's run is there's a lot of players. There's a lot of players in regards to how the patient gets the prescription. So when we think about the payer is usually the employer or the insurer, like a health plan, Medicare or Medicaid, and the patients have that coverage. The manufacturers are providing the product, and the pharmacy is getting the product from the wholesaler. But the biggest entity right now that affects the entire system is pharmacy benefit managers. And this is not a lecture to talk about the pros and cons of pharmacy benefit managers, but the hardest problem with what we have with pharmacy benefit managers is right now we have a monopoly. We have laws that are not always fair both ways. And so a lot of what's occurred in pharmacy over the last several years, if we've seen a decrease in reimbursement. Does this mean that you can't own a pharmacy business and be successful? Absolutely not. You can. You just have to be very proficient, very savvy in how you manage, how you plan, how you staff, and how you purchase. And that's the purpose of this course and next course if you go on to develop your business plan. This is a more expanded view of the distribution model. And so, how does a community pharmacy get paid? Well, community pharmacy gets paid the majority by filling prescriptions right now. That's why you hear me talk so much about us needing to look at other streams of revenue. But if you take a look at this model, here's the patient. They come into your pharmacy. You, the pharmacy, have to have a contract. And next semester, we'll actually talk about contracting a little bit. But you either get a contract by directly contracting with the pharmacy benefit manager, such as CVS Caremark or Express Scripts, or you also can join what's called a PSAO. And a PSAO is an organization that you would join, and there's several of them out there, and that organization acts in your behalf and negotiates a reimbursement from the pharmacy benefit manager. And the negotiation of the PSO does give a little bit of advantage because unfortunately the pharmacy, it's kind of a take it or leave it contract. And a lot of times in the PSAO it is too. So there's not a lot of negotiating power, and that's where the kind of the discord right now in 2019 is with pharmacy benefit managers. The goal of a pharmacy benefit manager is to create the network so pharmacies can be in it. However, sometimes in networks, it's all depending upon what the pharmacy is willing to give up in terms of discounts. And the third party payer is paying the pharmacy benefit manager to manage the prescription plan. In turn, what does that pharmacy benefit manager do? As I said, they set up the network, they negotiate with the manufacturers for rebates, and where the argument is the payer, whether it's an insurance company, whether it's Medicaid, Medicare, an employer, are they getting the true savings that they're supposed to from the pharmacy benefit manager? And is the patient getting the true savings from the pharmacy benefit manager? But the way a pharmacy gets paid today is they either directly contract with the pharmacy benefit manager or the PSAO. And then the pharmacy, in turn, has to be very good at purchasing, so they can purchase from a primary wholesaler, or they can purchase from a primary wholesaler and some group purchasing organizations, because unfortunately the price of drugs changes day to day. And sometimes you have to go out and find what is the cheapest medication. Pharmacy systems have gotten advanced. Currently, our pharmacy system can actually every day look and compare our primary wholesaler and the group purchasing organizations and look at what is the best price out there. The way you get paid too in a contract is it's either written as AWP, or which stands for average wholesale price, or you get paid by what stands for wholesale acquisition price. But in general, what a pharmacy is usually doing is if they're purchasing from a wholesaler, they're usually getting brands at maybe about 1%. They're paying 1% above cost of what the true cost of the drug is. And for generics, it varies anywhere from 20 to 50%. However, when you're looking at the payment from a contract, all right, your goal is that you purchase significantly cheaper than what either the AWP is, which is an estimate of the price retail pharmacies pay for drugs from the wholesaler distribute, or they use what's called WAC, which is another estimate of the price. And there's been a whole argument of how do we determine what truly is the price of the drug and what's fair? Because in theory, in most businesses, what do? You have what it cost you to purchase this, you have a markup, all right, and then you sell it. But not in our contract world. This is an example. This is an older contract, but they haven't changed much except the numbers might have gone down a little bit. But for example, this contract takes AWP pricing, which is an estimate listed by the manufacturer, and that is a standardized number, and they take AWP and they take a percentage off that because they know the pharmacy is buying cheaper than that. So on brands, usually pharmacies are buying at least 19% below AWP, and on generics they may be buying 50% below AWP. However, a lot of times those AWP contracts can be as high as AWP minus 18% or 25%, and they've gotten a lot more convoluted over the years since 2013, and that was only 6 years ago, where they are the biggest problem is we don't get a dispensing fee, and a dispensing fee is something that, should represent what you're doing as a pharmacist. And that dispensing fee varies anywhere from, 50 cents to, bucks 75. Sometimes it's also geographic. Sometimes if you are in a rural area, sometimes your dispensing fee might be higher, especially if there's no pharmacies around you in a certain distance. So the biggest challenge we have, though, in how do we combat these contracts is how well do we buy? And the biggest thing, too, is how well we price when we do have cash customers. And so we want to be fair to our cash customers, but unfortunately, $4 prescriptions don't cut it. You may do 90 days for $10, but usually you have to make anywhere from $10 to $11 per prescription on average to be able to survive. And it's kind of a crazy business that you may make a lot of money on some types of prescriptions, and some prescriptions you actually may lose money. And although that's very hard and difficult to explain, the overall goal is you want to look at what your average monthly cost margin is, because you want to make sure you're covering your cost of dispensing. The other key thing in able to survive as a traditional and be successful as a traditional community pharmacy is how well you manage your inventory. Because a lot of times, and we'll talk a little bit more about this in other lectures, but a lot of times if whatever you purchase, when you bill out to the PBM, if it's a Medicare contract, you're going to get paid excuse me, within 3 weeks on average. If it is a commercial plan, you're going to get paid within 4 weeks. Now, that contract pricing, all right, when you pay your wholesaler, you may get a discount for paying, ahead of time. And so your biggest goal is whatever I fill today, I have to replenish, but I need to make sure that I replenish just enough so that I don't have, I'm not spending too much on my inventory. So for example, if I purchase something that I may only sell every 3 months, all right, then I better only just be keeping a bottle of that. And so your inventory storage and your revenue collected and your inventory purchases, that is why when we talk about financials in the coming weeks, we want to look at financial turns. And that's going to be a big play in evaluating how, good your pharmacy is doing in managing inventory, because managing inventory can have a big impact on your cost of goods, which can have a big impact on your initial gross margin, which your gross margin is what you use to cover your operating costs. And we'll go into more detail. So that's traditionally how a regular community pharmacy stays in business. However, there are opportunities for pharmacies today to look at other streams of revenue. There's opportunities for pharmacy businesses to help participate in the healthcare system in helping with this value-driven healthcare. And I know all of you have heard me talk about this in both American Healthcare and in Pharmacy Practice 6, that we are in this value-driven healthcare. And we're going away from fee-for-service to value-based healthcare. And pharmacy can play a big role in that, because pharmacy services have been shown to lower the cost of overall utilization of medications and improving outcomes such as preventing ER visits and hospitalizations. We in the community pharmacy world have been challenged since 2012 in a lot of our traditional third-party contracts through pay for performance. And star ratings have played a big role. We're seeing pay for performance contracts being done with health systems now. Hospitals who get penalized for patients getting readmitted in less than 30 days. Doctors losing reimbursement on their Medicare because they're not meeting quality measure goals. So pay for performance is an opportunity for a good pharmacy service to help improve that. One of the best ways a good community pharmacy can survive and be able to offer additional services is incorporating medication synchronization. Medication synchronization used to be like a dessert for pharmacies. It was like a little add-on service to offer to customers. But in my true belief, medication synchronization is a must for all community pharmacy. It's our vegetables. Why is that? Because a lot of our pay-for-performance contracts play on adherence. A lot of our healthcare partners are looking for pharmacies that can help them make sure their patients are taking their drugs the way they should. The other advantage of med synchronization, it helps you from an operational standpoint. If I have greater than 50% of my patients who are on chronic medications synced, then I can then dictate what my staffing needs are. I can dictate and free up my pharmacist to be able to do other things, such as, perform medication therapy management services, be able to offer immunizations. And synchronization can allow us to control our inventory better. Therefore, as I was talking about earlier, that we can be able and be more savvy in our purchasing and managing of our inventory. This is just an example of some of the PBM contracts and how they affect pharmacy reimbursement, especially in Medicare Part D. So, for example, they are looking at, let's look at Aetna, for example. Aetna is looking at, is your patients on statins, on oral diabetes medications, on renin-tension system drugs like angiotensin II blockers and ARBs, are they adherent? And if they're not at least 85%, they're going to take a percentage. And that percentage is what's called a DIR fee. And it stands for direct indirect remuneration. And this DIR fee was something that was written in Medicare D, and probably the law was not meant to be the way it is. The law was meant to be a way to share the rebate savings that the manufacturers were giving the PBMs. It was also a way to incentivize the PBM to take care of patients better. But this is trickled down to pharmacy. And what happens is, even if I'm at 85%, no matter what, they're going to take 3% of what I get paid in my brands. And if I'm really bad, I'm going to get taken away greater than 3%. And Humana and Optima can take away 10%. So for a $500 drug, they're going to take $50 back if my patients are not meeting those adherence rates. And so what synchronization, what having pharmacies having adherence programs have shown a big difference in doing this. We have one pharmacy, by changing our pharmacy system and also getting better at our synchronization, compared to 6 months ago, we've saved $9,000. That is one way pay for performance and value-based healthcare can be, through med synchronization. Other opportunities can be in partnering with physicians. One area that I'm strongly looking into is chronic care management. Chronic care management is a way that physicians can do that incident to billing. So if I partner with a physician, they can actually bill for my service, and then they would contract with me and pay me a percentage of that. And chronic care management could be done during med synchronization. Chronic care management could also be done by a consultant pharmacist or a company that offers that. Because, as I said, why pharmacy plays a big role, because drugs help control diseases. Drugs, if they're taken right, if they're given the right drug, if they're adherent to the right drug, they have better opportunities to meet the patient's demands and help the patients, but in turn help the healthcare providers. So, like I said, you could have a clinical service which brings in additional revenue just by being part of your workflow. But whatever service you do, you want to look at how does this service bring value to the people that I want to partner with. And as you are developing an entrepreneur business, what is the return of investment of your pharmacy business to other providers, patients in the system? So, as I've said numerous times, we want to ask ourselves, how do we solve our partners' problems? How do we make our partners feel good? So when you're developing a business plan for a service, for a pharmacy business, how does your business meet the needs of those who you are going to target market to do that? Pharmacy services can have a big impact on, for example, HEDIS measures. And HEDIS measures are measures that, evaluate how well physicians are doing in a health plan, how well the health plan is doing in taking care of their constituents, their patients. And so, for example, making sure they're on the right drugs for their disease state, making sure their blood pressure is under control, making sure that they understand how to take certain medications to control their diseases such as asthma, psychiatric disorders. And so there is a potential pharmacy value that offers. And, there's lots of different ways pharmacy can get paid for this. And they can get paid, by joining such as, certain healthcare organizations. You could be a consultant. You could offer a service where you get paid so much per member per month to take care of them. You could be in a shared basket where the better the patient gets, you might get more in your contract, in your reimbursement. And so there's numerous ways that pharmacies can offer value-based incentive services. And as we will begin this coming week, we're going to talk about, profit loss statements. And profit loss statements do this. They look at your sales and they look at your costs and they look at your expenses. And the overall goal you need to do is, how do I manage those? How many employees do I need? What is my lease? What is the utilities I need? So all of those things play a big role. And so you can have a great service, whether it's a traditional community pharmacy or another business, to be able to do this. You plan financially. This is an example of a way to calculate what it costs to dispense a prescription. You would look at your direct cost, your employee salaries, your total hours of your employees, your indirect cost, the pharmacy department sales, and the number of prescriptions dispensed. I gave this example in Pharmacy Practice 6, but this is an example of looking at financials. And like I said, this is kind of a precursor to our financials, but it's planning out. And how do you plan out? Well, you would start small. So if I'm starting a service, I may say that I may capture 5% of the business of this service, of this area. I may evaluate how many people are in this area that I could potentially use. So for example, if I marketed that I have 200 potential patients and I'm thinking maybe I will get less than half of them, or maybe just a third of them, what would I benefit of this service? And so forecasting is something we'll teach. And as I said before, the way we can get paid is contracting, collaborating with physicians. Right now, it doesn't matter if your business is, a consulting business or offering a service. There are certain ways you can get paid by being in the pharmacy, and there's certain ways you can be paid by out. And the one successful opportunities that I believe for pharmacy businesses that offer clinical services, it's partnering with physicians, because physicians, by collaborating, can pay for your various services. And so this is just an example of, how clinical services can play a big role. And so that you can play a role in chronic care management. You may do that by pharmacogenomics. You can do that with collaborative practice agreement. You could do that by diabetes education. You may look at getting into, a business where you're improving transition of care. You may offer a bedside delivery program. You may partner with physicians to do transitional care management. You can get into point of care testing where you're, testing things such as strep throat, doing disease screenings. You can get into adherence, MedSync. You may want to address the opioid epidemic. You may look at pain management programs, dispensing of naloxone. You getting into preventative health, offering immunizations or smoking cessation. So all of these services are ways to build revenue. One of the things we're going to talk about over the next couple of weeks is just basic financials. But I want you to start thinking about to yourself, how can I bring those services bring in money? They can bring in money by people directly paying you. They can bring in money by partnering with partners like physicians to be able to bill for the services you do. You also, in some areas, depending upon the state, may be able to get certain privileges by being part of a pharmacy care network or signing up with MTMs or getting certified to do certain things like diabetes education, where you can actually bill the 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 patient's insurances and get directly paid. So hopefully you've watched this. I do have an assignment, and the assignment is doing these third-party case scenarios. And I have you doing these third-party case scenarios because I want you to get a good understanding of insurances. Because I think a good business person, regardless of what business you want to do, a traditional community pharmacy or partnering with physicians, is understanding that. Because a big role we play, whether we like it or not, is understanding that. So that assignment, once you have it due, I will do an overview of that assignment via tape for you guys to watch. But this is the beginning, as I talked to some of you already, that we are going to be doing financials, and that will start this Friday. Thank you very much.